Today I have the pleasure to introduce two of our senior professors intimately involved with the transplant program for a number of years. Dr. Francis Sharkey from the Department of Pathology and our own Dr. Sprague. And it's always a treat when we can combine these multidisciplinaries, or these various disciplines together and talk about our patients. So we're going to have case conferences and pathology slides that Dr. Sharkey will go over. So without further ado, I'm not sure who's starting. Dr. Sharkey.
I was saying we're both very senior.
Seasoned would be the...
Okay, I'll go for that. That's all right. That's fine. I can see the pathology turn the crowd down. The moment pathology is mentioned, everybody says, "Oh, I got away from that in medical school." Okay, so we're going to present several cases. Dr. Sprague has clinical information. I have the pathology that I'll be showing you with that. Couple of introductory words. This, believe it or not, is a liver. Liver weighs somewhere between 1,300 and 1,500 grams in most people of average size and weight. You're actually looking at the diaphragmatic surface of the liver here. This is pressed right up against the diaphragm. Liver sits right behind the rib cage normally, except for medical students when it's always palpable. This is right lobe, and actually the division between right lobe and left lobe is right about here. This is a ligament that comes in from the umbilicus, is active during fetal life to carry blood back from the placenta, but then closes off afterward. But that little notch persists through life. So this is a normal liver, nice smooth surface, normal tan color. This is an example of a cirrhotic liver. And this is rather grossly nodular, as you can see. And it's interestingly enough, I don't know why, but the proportion of right and left lobe size does change so that the left lobe becomes relatively larger in many cases, but not all cases, of cirrhosis. But you can appreciate the nodularity that's present. Microscopic normal liver, the portal vein, the hepatic artery, and the common bile duct enter the liver on the inferior surface right in the center and then arborizes out from there. These three things are carried in what are called the portal tracts. So here is a vein, here is bile duct, and here's the arteriole right there. They're all carried out, and the flow of blood, the portal vein and the hepatic artery, blood join together, and they flow from the portal tract through what we call zones 1, 2, and 3 of hepatic parenchyma into the central vein, which then has a completely separate way of getting out of the liver altogether. These zones are actually are functionally different. There is an oxygen gradient from the portal tract, as you can imagine, to the central vein, and there are different concentrations of different types of enzymes in these different zones as well. Probably clinically most important are the P450 enzymes, which supposedly detoxify certain things, various things, but which can also activate normal things like acetaminophen into a toxin itself. And these are most active in the central lobular area of the liver, around the central vein in zone 3, and accounts for the greater deleterious effect of these things in that particular area when there is a toxic effect on the liver. In contrast to, let me go back for a second, notice that the pink cells are the hepatocytes. In between are what are called the sinusoids, where the blood flows between them, and you can see their hepatocytes and the sinusoids are right next to each other in a very nice, even arrangement. Whenever we get inflammation, that correspondence of sinusoids and hepatocytes is lost. You can hardly see the sinusoids at all. The hepatocytes are piled on top of each other. The loss of that connection between the hepatocytes and the sinusoids makes the hepatocytes less functional and accounts for some of the loss of function in that kind of situation. This is a mass of inflammatory cells that are present in this inflamed liver. Liver also acquires collects certain things abnormally. In this particular incident, it has collected fat in somebody who has steatohepatitis. We call it both macrovesicular fat and microvesicular fat, depending upon the size of the globules, and they have different implications as well. The amount of fat is important. As the liver accumulates fat, that actually expands and gets bigger. So instead of 1,300 to 1,500 grams, you can have somebody with marked steatosis with 2,500 grams liver, and that's really quite a big change in size. Liver also accumulates things like iron, copper abnormally, and so on, and these are things that we test for as we look at the specimens pathologically. So with that little introduction, I'm going to ask Dr. Spieg to begin the first case.
So we have 5 cases of things that we see fairly commonly. There probably are 20 things that might have unique features on a liver biopsy or in an explant, but we can't do all of those at once. I would mention one of the most fun things about pathology in liver is sitting around the microscope with Dr. Sharkey, which we do once a month, and you're welcome to attend if you have an interest. It's usually the 3rd Wednesday afternoon. We can actually discuss the clinical presentation and the pathology and argue about what's there. So the first case is a 24-year-old man that presented originally with fulminant hepatic failure. He did get a transplant in September and did extremely well for about 8 months. He then showed up with the liver test that you can see there. Bilirubin was elevated, 4.7. Transaminases were quite elevated. Alk-Phos and GDT were also elevated. And ProGraph was 6.1, which we considered to be adequate for this time post-transplant. He was admitted, went through our typical cookbook workup, making sure hepatic vessels were patent. Really didn't have anything to suggest from the lab that the biliary tree was not anything but patent, and actually had a liver biopsy as sort of part of the workup on May 20th. We'll give it back to Dr. Sharkey.
Okay, so this is these are some slides from the actual biopsy. This is actually a portal tract. This is the lobular parenchyma on the outside. You can see that there's a little bit of obscuring of the sinusoids, but there's still a pretty good 1-to-1 ratio between hepatocytes and sinusoids. And the major disease process is in the portal tracts, as you can see here. This portal tract is markedly expanded. It's several times its normal size, and it's been expanded by all these blue dots, which represent inflammatory cells present in there. So this is all massive inflammatory cell expansion, and relatively little going on in the lobular parenchyma overall. Looking at this a little bit more closely, we can see that these are primarily mononuclear cells, large and small lymphocytes, but there are also these pink cells are eosinophils, and there's a scattering of eosinophils present in this inflammatory cell infiltrate. It's hard to see, but this was a bile duct. It's been almost completely destroyed by inflammatory cell infiltrate. And looking at the portal vein, you can see that the endothelium has been lifted off, kind of shredded looking in this. And you can see this a little bit better. This is a trichrome in which the collagen stains blue. This is a portal vein here, and you can see the inflammatory cell infiltrate is literally invaded through the endothelium into the portal vein. So we've got a relatively normal lobular parenchyma, inflammation that's pretty much confined to the portal tracts with destruction of bile ducts and endotheliitis. These are classic findings for acute cellular rejection, something we don't see all that often in the liver, and particularly by itself. We may see it associated with other things. In this particular case, again, we're looking at an expanded portal tract with inflammation, eosinophils present, and so on. One thing I noticed in this particular case, there's this phenomenon of what's called interface hepatitis, in which the portal inflammation seems to be crawling out into the adjacent lobular parenchyma, causing destruction of hepatocytes. And there's also an acidophil body. This is a hepatocyte that has undergone apoptosis. Apoptosis is basically cell suicide, self-induced death of a cell when a cell decides that it can't survive any longer. These are relatively unusual with acute cellular rejection unless it's very, very severe. So in this particular case, we have to consider the possibility that there may be something else going on in there, but that's pretty much for the clinician to decide to work on and to figure out. So I'll let Dr. Spieg go ahead with his.
So what happened to him? He was initially treated with high-dose IV steroids. His liver test did not improve, so the next step was to begin treatment with thymoglobulin. He actually required about 6 doses over probably almost a 2-week period. And actually, about a month after all this started, liver tests had returned to totally normal. He's still followed, and liver tests have remained normal, and I think he may have a new appreciation for why he has to take his meds.
So probably less severe rejection by itself.
Right. All right, the second case.
One question.
Sure.
The destruction of which cells cause the transaminitis?
Hepatocytes.
In this particular case, with severe rejection, there is destruction of hepatocytes, and you can see that with the interface hepatitis and the acidophil body.
So if there wasn't the interface hepatitis and just the inflammation within the portal tract, you wouldn't necessarily see a significant rise in the enzymes?
You almost always do see some, nevertheless, but certainly less than.
So case number 2 is a 52-year-old Hispanic man that had end-stage liver disease from hepatitis C. When we first encountered him, his hepatitis C PCR was 19,000 or so international units per mil. He eventually got a transplant in October of 2013, and the Hep C PCR was 819,000 at that time. It's important to know that it can just sort of wax and wane. It does its own thing. We never can sort of predict what it will be. Within about a month after the transplant, though, the Hep C PCR had gone up to 27 million. This really is not too unexpected. It's generally thought about a 20-fold elevation in Hep C after transplant with all the immunosuppression we use is not uncommon. And actually, a while after the transplant, the liver tests looked extremely nice. The only maybe footnote would be the GGT at 270. That's a little discordant with the rest of the tests, and sort of always makes us worried that, well, is alcohol involved, since that has the potential to exacerbate hepatitis C. He actually had a liver biopsy at about, so a month after that, he was seen in clinic and liver tests were no longer normal. Bilirubin was up, transaminases were up, alk-phos and GGT were up. And he actually had a liver biopsy at about that time, which was surprisingly benign. He had some evidence of hepatitis C recurrence, but it was quite mild. Over the ensuing months. Liver tests remained absolutely abnormal, up and down, never did return to normal. His Hep C PCR, however, dropped to 6.7 million. And during this time, we were trying our best to get him into a hepatitis C treatment protocol with our colleagues downtown. And the way the study was constructed, this man's enzymes were always too abnormal to be included in the study. He did have another liver biopsy in July, and Dr. Sharkey will tell you what it showed.
Okay, so this biopsy is an interesting contrast to what we saw previously. Previously, we saw an example of acute cellular rejection. This is an example of recurrent hepatitis C, and probably more than half of the biopsies we received, the basic clinical differential is recurrent hepatitis C versus acute cellular rejection, and each has its own features that help us differentiate. Here again are a couple of portal tracts. There's a little bit of mononuclear cell infiltrate present. Here's the other one in this photograph, but it's not nearly as marked as we saw with the acute cellular rejection. And then in the intervening lobular parenchyma, there is considerable. Again, all these little blue dots represent inflammatory cells that are involved in destroying hepatocytes that are infected with hepatitis C. Here's a portal tract again. There's a little bit of inflammatory cell infiltrate, but it almost avoids the portal venules, almost avoids the bile ducts that are present, instead of crowding around those, as we saw in the case of acute cellular rejection. And out in the lobular parenchyma, there's all this inflammatory cell infiltrate with destroyed hepatocytes. Here's an acidophil body. Here's another acidophil body. Again, these are hepatocytes that have undergone apoptosis. That's, of course, where the enzymes are coming from. A couple of special stains that we use to evaluate special things in there. We do a trichrome stain to look for excess of collagen present in the liver. If you look back in here, there actually is excess collagen present in this portal tract, but you can't really tell very well because everything is pink. So we do the trichrome stain, and the trichrome stain stains the collagen nice and blue, and it's perfectly clear that this portal tract has been expanded, fibrosis, and it's extending further out into the lobular parenchyma. So that gives us an idea of how much pretty much permanent damage is present in this liver. This, on the other hand, on the right-hand side is what's called a reticulan stain. Reticulan is a form of collagen that surrounds, that lines the sinusoids of the liver and seems to almost surround the individual hepatocytes. When a hepatocyte is lost to disease, those fibers stay there, and you see these tangled skeins of reticulan fibers present in the lobular parenchyma as evidence of hepatocyte loss, in other words, disease activity. And it's very helpful, especially when you have a case with relatively minimal inflammatory cell infiltrate and elevated enzymes. This can help you identify that there is abnormality present in the biopsy. We do have ways of what we call grading and staging chronic hepatitis in the liver. And of course, recurrent hepatitis C is a form of chronic hepatitis. We use the Ludwig Batz grading and staging system. It's very simple. It's easy to apply. There are other grading and staging systems that are more complicated, oftentimes used only in a research environment, but that varies a lot from one place and one practitioner to another. Dr. Spieg has been very kind in agreeing to go with a nice simple system like the Ludwig Batz. So grading, in other words, disease activity, depends upon the amount of portal infiltrate, the spread of the portal infiltrate and as interface hepatitis, and the presence of inflammatory infiltrate in the surrounding parenchyma. So we go grade 1, grade 2, grade 3, grade 4. fairly simple to apply and not that difficult. Where we get into trouble in applying this is when the inflammatory infiltrate is confined to the portal tract and is showing interface hepatitis, but nothing in the lobular parenchyma, or vice versa. And in the post-transplant, immediate post-transplant situation, first couple of months, we will often see a lot of lobular disease and almost no portal tract disease whatsoever. So Liver is tough to apply in those kinds of circumstances. Staging of chronic hepatitis it depends upon the amount of fibrosis, number one, and the amount of architectural derangement. Stage 1 has a little bit of excess fibrous tissue in the portal tracts. Stage 2 out of 4 has more fibrous tissue and a rare focus of bridging, such as you see here, between portal tracts. Stage 3, rather extensive bridging, but still a retention of the architectural correlation between portal tracts and central veins. And stage 4, extensive fibrosis, bridging fibrosis, and regenerative nodule formation. So in other words, complete architectural derangement in stage 4. A fairly simple system, very easy to apply, and actually fairly consistent from one person to another. We run into problems with this in that a biopsy, individual core biopsy, depending upon how thick or narrow, how wide or narrow it may be, is only about 40% of the width of one of these. One of these areas. So you can imagine not being able to see, excuse me, let me get back here, not being able to see all those portal tracts, but only seeing a portion of them and trying in your mind's eye, trying to take what you're seeing and, spread that out to the rest of the liver. It gets difficult, and you'll often see reports that will say stage 2-3. In other words, I can't really tell if I'm dealing with a stage 2 or a stage 3 in this case. Nevertheless, it is useful to the clinician. Maybe Dr. Spieg would like to comment on that. Any questions about this pathology before we go on? Yes?
So I know pre-transplant, a lot of the damage is due to the immune system's response to the hep C virus. When the viral load gets that high, does the damage come from the virus itself, and there's a difference in the histology, if there's a difference in the pathophysiology?
I think that's all I need.
It does in part. The immune system is still involved, but once the PCR is sky high, it's felt like the virus is cytopathic also. Our actual record holder was 1.2 billion as an international unit per mil, so then she did not do well. All right, so basically with a marked deterioration in the biopsy result from one to the other, we really thought this liver was being eaten up by the hepatitis C, and would be. Fortunately, the new medicines became available, and this is sort of what he got started on them, and this is sort of what happened. Basically, about the day before he started, PCR was about 3.9 million. All enzymes were pretty elevated still. A day later, he started the medications, and about 2 weeks later, there was just a remarkable improvement both in the function and a drop in the hepatitis C PCR.
What antivirals?
He started on 2, sofosbuvir and cimipravir. That was sort of what was available to us on that date. The studies we were trying to get him enrolled in have there are a lot of them, and there are a lot of new medicines, and we're always being told that what's in the pipeline is much better than what's coming out. So this literally was the first opportunity to put him on something that was not interferon based. Okay, case 3. This is a 30-year-old African-American lady, absolutely healthy all of her life until presenting in one summer with fever, white blood cell count of 36,000, and abdominal pain. She had a fairly rapid and extensive workup and was found to have a metastatic thymoma, most of which was confined to the lungs, actually. She was treated with broad anti-neoplastic drugs, all of which have their own hepatotoxicity: adriamycin, doxycycline, vincristine, and Cytoxan. And her last dose was in December. This was followed by a surgical resection of what was left of the thymoma, and then she began sort of broad XRT on March 16th. Liver tests during this time were amazingly normal. So a month later, there's some concern because her albumin is low, her bilirubin is actually quite high, she's jaundiced. Transaminases were way up, and alk-phos and GDT, or at least alk-phos, was up. Workup was started, and the only positives, I mean, all viral etiologies were ruled out. The ANA was probably positive with what's called a homogeneous pattern, which is what you would normally see with drug-induced autoimmune problems. The anti-smooth muscle was barely positive, upper limit of normal is 20, but the IgG was also elevated, upper limit of normal being about 1,600. So the only things that were positive during this time were a few autoimmune markers, and they were not particularly convincing, as a matter of fact. So anyway, she had a liver biopsy.
So this should begin to look a little bit familiar. By this time, we have a portal tract here. You can make out the individual bile ducts that are present. There's a fairly heavy concentration of inflammatory cells present in there. You can see interface hepatitis, this spreading out of the inflammation into the surrounding lobular parenchyma. And then there are also mononuclear cell infiltrates in the lobular parenchyma itself as well. So we have both portal and lobular hepatitis. And I think you can see also that there look like almost like clusters of hepatocytes rather than the individual one or two hepatocytes to one sinusoid. So we've got lobular disarray as well, which is a common finding whenever there is inflammation and hepatocyte damage going on in the lobular parenchyma. Looking a little bit higher power, you can appreciate that there is the interface hepatitis. There's a little necrotic hepatocyte here. But notice that the inflammatory cells that are present in this and in the interface hepatitis, these are plasma cells. Now in hepatitis C, for instance, and other forms of viral hepatitis, the cells involved in interface hepatitis are lymphocytes, not plasma cells. You may see an occasional plasma cell, but you typically don't see clusters. And the clusters of plasma cells are not only present in the portal tracts, but they're also out in the lobular parenchyma as well. And these are common features of autoimmune hepatitis present in a liver biopsy. They're not necessarily diagnostic 100%. They're neither 100% sensitive nor specific, but in put together with clinical findings, these findings help to make the diagnosis of autoimmune hepatitis in the liver. This is a trichrome stain. Although this patient had a fairly acute presentation, nevertheless, even when we see an acute presentation of autoimmune hepatitis, we typically will see evidence of fibrosis present, increased fibrosis, and it's the kind of fibrosis that doesn't occur in just a week or two. So this disease has actually been going on fairly silently in this patient for a longer period of time. Here's a portal tract. Here's a portal tract over here with the bile duct, and you've got this little fibrous bridge that is connecting them. So it's the beginning of bridging fibrosis present in the liver. Here's another, probably a bridge going out that way, probably another bridge going out this way as well. So there's evidence of chronic disease present. And when we report this to the clinician, we use the same grading and staging parameters as we do for other forms of chronic hepatitis. A word of warning, those grading and staging criteria were developed for viral hepatitis, not for autoimmune hepatitis or drug-induced hepatitis or anything like that. So a clinician has to take what we grade and stage this with that in mind and take it with a little bit of grain of salt. It may not be as meaningful or may not mean exactly the same thing as it does with viral hepatitis. But we don't have a better system to grade and stage what we're seeing in this particular disease process. Any questions about that pathology?
So this would be grade 3, stage 3?
This would, no, you're not seeing the whole liver. I'm showing you the best example of bridging. This would actually be stage 2. In order to be grade 3, I would like to see confluent necrosis between portal tracts. This is be more closer to a grade 2. Although I will admit there's quite a bit of lobular disease as well. So, okay. Right.
Hey, Vince, can you get closer to the mic? You're fading out on us.
All right. So these cases have been things we see commonly. So what happened to this lady? She was treated with steroids initially and eventually had azathioprine added. It took a while, but her lab eventually normalized and she remains on some dose of prednisone and Imuran and hopefully will stay with normal liver tests. Since we really don't know whether this was provoked by the thymoma, whether it was provoked by the chemo she got, or whether this is just bad luck and autoimmune liver disease just sort of happened, it's sort of hard to know what exactly her prognosis is. When autoimmunity was, as a liver disease was first described, it was pretty clear that even the treatment with steroids and azathioprine and normal liver tests, for some there was still progression of the fibrosis ending in cirrhosis. Keep your fingers crossed.
She may have steroids as part of her thymoma.
Actually, she did not. I don't know why, but if she did, they never mentioned it. It was just the big four. I don't think they gave her cisplatin, but I couldn't think of a more toxic regimen than what they concocted.
Just one quick question. So autoimmune hepatitis, autoimmune process, you imagine it to be a systemic illness, similar to the kidney autoimmune. Why is it isolated to one organ then, or is it? Do you see other organs or other features with autoimmune hepatitis?
That's a good question, and I don't know the answer. It does seem to be sort of localized to the liver. So the immune system is so complicated, I think probably you have activated a certain part of it. I mean, there's an innate immune system that's always on the alert and ready to do something for anything that needs to be cleaned up. But for instance, like lupus, for instance, which is clearly systemic and multi-organ, rarely ever affects the liver at all. So, I mean, just a lot of unanswered questions, but when you see the pathology and the autoimmune markers and the abnormal liver tests, that's pretty much where it's going to be, the liver and nowhere else. Okay, case number 4. It's a 57-year-old Anglo man, a really extensive alcohol history. He estimates that he was capable of drinking 4 or 5 bottles of wine every night. He depends on how big the bottles are, I guess.
It's not a problem if you drink less than the doctor. So.
For him, it was. He actually presented at an outside hospital where they treated him for really severe alcoholic liver disease with steroids. And he was one of the ones that did improve. So after his bilirubin had dropped from 35 to 16 or so, they sent him to us. The rest of the liver tests don't look so bad in a way. Albumin is still barely normal. Transaminases are not very high, which is a key feature of alcoholic liver disease. Alk-Phos and GGT were not too bad either. Cholesterol was 315. Iron sats were 84. Ferritin was 886. His INR was 2. Platelets were 47,000. So he had really not had much to suggest chronic liver disease. He had not had any GI bleeding, ascites with bacterial peritonitis, or spells of hepatic encephalopathy. His other medical history was pretty benign. He had his first blood transfusion on presentation to the other hospital for pretty severe anemia. Remember, that kind of alcohol intake is toxic to your bone marrow, so probably everything looked bad. And basically went through a workup here, and it was pretty clear that it was going to not improve significantly. He had a transplant in May, and Dr. Sharkey will tell you what that showed.
So this is a very different picture from what we looked at before. This is a rather low power, and these areas that I'm outlining here are wide fibrous bands, and then these are regenerative nodules surrounded completely by fibrosis. So we have a completely cirrhotic liver in this particular case. And again, regenerative nodule, very irregular outline to the pattern of the nodules, suggesting ongoing active disease. Looking at this, looks like garden variety cirrhosis microscopically. Looked at a little bit more closely, there's more interesting information. Not sure how well that comes across on the screen, but there are hepatocytes here with brownish pigment present inside. There's basically three different brownish pigments that we see. We see bile, we see lipochrome pigment, so-called aging pigment, that accumulates and does not known to have pathologic significance, and we see iron. The bile and aging pigment collect predominantly in the central lobular area. Iron collects predominantly, or at least begins collecting, in the periportal region. In a cirrhotic liver, close to the outside of the nodules. So that's a reasonable presumption in this case is what we're dealing with. In order to prove that that brown stuff is iron, we do an iron stain, which turns the iron a blue color. And each of these clusters of blue granules is a single hepatocyte that is just loaded with iron pigment. And this is a very heavily stained iron stain. Typically, normally, when we do an iron stain on a liver biopsy or a hepatectomy, we see no staining whatsoever. That's the normal feature. And instead, every cell that you can see here is loaded with iron. There's one other thing that's a little bit hard to see, but this is a bile duct present, and the individual cells of the bile duct are also staining positive for iron. Now, for instance, if we see an alcoholic, we would call this 4+ iron, 4+ out of 4. Alcoholics frequently will have lesser amounts of iron, 1 to 2+. They typically do not have staining of the bile ducts. It's when we see heavy iron and bile duct staining that we're pretty certain that we're dealing with a hemochromatosis-like condition. Not necessarily exactly hemochromatosis, but certainly dealing with clearly pathologic accumulation of iron in this case. Here is an example of liver with a heavy amount of iron present. Notice it's slightly rust-colored. It really is rust-colored, and the iron does provide that coloration to it. And if you do that same iron stain on it, it turns the same blue as you see in this particular case. So, nice example of hemochromatosis, cirrhosis related to hemochromatosis, stolen from some other book.
So this is one of the interesting things about getting the explant is there are surprises. I don't think from his iron saturation and ferritin level, we would have guessed he had this degree of iron overload. The rest of the workup was that the genetic testing for hemochromatosis for him was wild type. He did not have either of the gene mutations that are known to be associated with hemochromatosis. And the footnote there is most people who have the mutation don't have iron overload. So you could ask how helpful is that really? Now there are other genes that are known to have a place in iron transport. One that we don't actually have a good test for at this point is called ferroportin. We have a lot of cases of this. I would guess more than 20, and most of them do not have what's considered the typical gene mutation for hemochromatosis. So we would guess it's probably a mutation in ferroportin. One of the things when Dr. Sharkey sees that degree of iron that we do as a follow-up is send a piece someplace for a quantitation of iron. It did go to Mayo Clinic, and now it's going to Quest. And they have their own way of what they do is they dry it so they express things in micrograms of iron per gram dry weight. And a value, and that's called an iron index. It's basically also age dependent, so that's compensated for. A level up to 1 is considered normal. Up to 1.9 is confusing, and over 1.9 is consistent with hemochromatosis. This man's iron index was 4.3 or something like that, so met all the criteria for it, just didn't have the genetics.
So, Francis, can you remind me and the audience, iron overload, but what is the metabolic issue that causes that?
Well, whatever the genetics is that you end up with this, you absorb iron from your diet and wherever else better than a person who does not have one of these genetic lesions. And because it's diet, it all goes right into the portal circulation and to the liver. And if you can't get it out of the liver, then it eventually stains like this, but it also, some does get out of the liver. It loves to go to the heart and reside there. It goes to the endocrine glands and resides there. So these patients actually have a systemic problem, and you have to sort of, if you know it ahead of time, you can deal with it. In a patient like this, where you don't know it ahead of time, the difficulty gets to be what happens when you do a liver transplant. The old literature would say that hemochromatosis, transplanting hemochromatosis was hazardous. The outcome was about 50% mortality, and it was all heart failure. Way back when, we had a few cases that died of heart failure sort of unexpectedly. I mean, it wasn't like they had a heart attack, it's just that the heart didn't work. So they had the cardiomyopathy that goes with this. At one point in time, we actually had some enthusiasm for biopsying the myocardium. We haven't done that recently, but we haven't had any reason to suspect it for most of the patients who ended up with the disease.
So presumably it's a hepatocyte issue, so the liver transplant cures the hemochromatosis.
Because it's a genetic illness, almost certainly, it cures it for a while. So for all of these patients, we follow the ferritin and the iron saturations fairly closely. With the C282Y genetic mutation and iron overload, basically you can expect the ferritin will go up, and you'll have to phlebotomize those patients at some point. with the ferroportin, if that's what it really is, we don't really see the iron reaccumulate very fast. So very few of them have had to have phlebotomy, as a matter of fact. But no, it cures it for a while. I mean, the bottom line is men, from the time they're born till whenever, accumulate iron. Women, it's the opposite. As soon as they begin having periods, they lose iron until they hit menopause, then they gain iron with time.
Is it possible to give somebody hemochromatosis from transplant?
Yeah, it's a genetic thing. That's a good question. I don't think so. We've never had to worry about it because now we get our zero-time biopsy, or frequently there's a biopsy on the donor that's known. So iron overload usually doesn't seem to be a problem. With cirrhotics, it's the opposite. They're usually very iron deficient from variceal bleeding. All right, last case. This is Harvey, for those of you who remember him. He's a 24-year-old soldier who presented with fulminant hepatic failure. Workup for him was negative, except that he used a supplement called hydroxycut. The nurses all thought he was pretty buff, so I think it must have worked for him. That was the only real risk for liver disease that we could find. On presentation, his albumin was actually normal. Bilirubin was 36 or so. Transaminases sky high. Ferritin 4,600. You might worry that's too much iron. Remember, it's an acute phase reactant also. It isn't. The liver's full of it, so when you just ruin the liver, level will go up. INR was 2. Factor V activity was surprisingly normal, as was the factor VII activity, was a little low. He clinically looked awfully close to normal, so he was being observed, and at one point we were just trying to decide, is this guy going to need a transplant or not? And the clinically and the way his lab looked, it was just absolutely impossible to decide. And one of the things we sometimes do, if the coags allow, is to do a liver biopsy and see how much damage is there. And it used to be that if it looked like it was 50% or more destroyed, you better get ready for a liver transplant. I can't remember honestly what his was, but it was pretty scary. He began to clinically decline. He became encephalopathic. He was lucky enough to get a transplant. So this is what it looked like.
This is not actually this patient's liver, but it is something very similar. It shows a liver in a patient with what's called submassive hepatic necrosis. And in hepatic necrosis, what happens is you lose so many hepatocytes that the liver begins to shrink, and the outside surface gets wrinkled in the way that you can see in this particular example. It just shrinks so much as a result of loss of hepatocytes present. I guess this again is our normal liver, portal tract, hepatocytes, central vein, and the biopsy and the hepatectomy specimen were essentially similar in this patient. Here is a portal tract. Here are a couple of central veins, and what's missing? Hepatocytes. There's no hepatocytes left. They're just completely gone. This was not universally present throughout the liver, but probably 70 or 80% of the liver looked like this. There was not enough, basically, to sustain life. And when there's this degree of loss, there's almost nothing left to regenerate that liver. Generally, the liver regenerates extremely well if the reticulan framework is preserved. In this kind of situation, the reticulan framework is not preserved, and even though you've got these structures here that are called ductules, which are actually trying to regenerate, they're like stem cells in the liver, and they're going to try. If this patient lived long enough, they'd be trying to regenerate hepatocytes. Nevertheless, there isn't the reticulan framework left to allow them to fit in properly and to and to function effectively within the liver. If the patient had survived, if there had been enough viable hepatocytes, probably would have ended up with a cirrhotic liver due to regenerative nodule formation rather than regeneration within the normal framework such as we have here. We often don't see complete necrosis like this. More commonly, we see partial necrosis. This is an example of, here's a central vein in which there's been extensive loss of hepatocytes in this particular case, and there's actually a hemorrhage in this area. Here is portal tract is perfectly normal. Remember I mentioned earlier that the P450 cytochrome enzymes that are in greatest quantity in the pericentral area can not only detoxify, but they can also take normal products and turn them into toxins, such as with alcohol or with acetaminophen, and cause damage to hepatocytes as a result of that. So this is an example of that sort of damage that we see there, and it has not affected the entire lobule, but only part of it, and this can probably regenerate quite nicely in this particular situation. Not our patient, however. So do you want to continue with, sorry.
The cases, if there are questions.
What, were you convinced it was due to the hydroxycut?
It's been described with hydroxycut in the literature. We could find no other cause, so we were convinced.
Because he had just gotten back from Iraq also, right?
Right, he was active duty over there. I think there must be downtime where they're bored, and so they go to the gym a lot. That's what he told us.
But it's got to be extremely rare because all those guys take hydroxycut out there.
They've changed the formulation of that.
Right, several times.
4 or 5 times, yeah. I don't remember what formulation you had, but it's been changed a few times.
As soon as they bump off a few more patients, they are forced by the.
And you still see Harvey?
Yeah, he's doing well.
He's not active duty. He was boarded out.
I don't remember that part. All right, thank you.
We'll be having a similar presentation by nephrology.